Good morning and welcome to the first plenary session for Saturday of our 9th Annual International Coronary Congress. I'm joined here at the podium by Dr. Antonia DiFranco. Hiro Arai will arrive shortly, I'm sure. We will get the program started on time. This is the session devoted to preoperative imaging and functional evaluation in coronary artery bypass patients. I think it's a terribly important concept for us as thoughtful coronary surgeons and cardiologists. So I'm going to ask Dr. DiFranco to introduce our first speaker.
Thank you, Professor Puskas. It is a true honor for me to be here this morning, and it's an absolute privilege for me to introduce my friend and mentor, Professor Jonathan Weinsaft, who's the Chief of Cardiology at Weill Cornell. Professor Weinsaft is a world-esteemed physician-scientist who focuses on clinical research and cardiovascular imaging. He's the recipient of several awards from international societies. He directs the cardiac MRI program at Cornell and is the lead author of hundreds of publications in the field. But it's not only his professional achievements that make him special. Professor Weinsaft is in fact a passionate advocate for educating the next generations to the importance of clinical research, making him an inspiration to many. So please join me in welcoming Professor Weinsaft, giving us his talk about the meaning of viability studies.
Thank you very much, Antonino, and thank you for joining me this morning. So I'm going to be speaking this morning on preoperative imaging, functional evaluation in CABG patients, with focus on prior viability studies. I'm going to focus today on a new technique in terms of availability and increasing utilization in the preoperative setting. And that's cardiac MRI, which is increasingly emerging as a gold standard reference for assessment of both ischemia, meaning impaired perfusion, as well as infarction. We're going to be talking about what CMR is, its impact in terms of viability assessment, and our ability to interpret prior multi-center studies with regard to their impact on CABG patients. When we talk about CMR, the key concept that I'd like to impart to you today is that the test is really not one thing. It is many different approaches for looking at cardiovascular physiology rolled into one modality. It's not simply viability testing alone, meaning is the muscle alive or dead. It's the ability to look at flow, myocardial perfusion, cardiovascular function, as well as anatomy, and complications of myocardial infarction. In one single test. What does it do better than other techniques? Well, it can assess whether muscle is alive or dead, but importantly, it can assess whether there is ischemia superimposed upon it. Let's talk a little bit about this in terms of things. First, a key concept: is all ischemic disease irreversible? Well, absolutely not. We know the notion that myocardial dysfunction may be due to infarction with scarring, but it can also be due to myocardial hibernation, a state of chronic myocardial downregulation in terms of metabolic activity that occurs in response to chronic ischemia and is potentially reversible. So we can have normal myocardial function exquisitely defined in terms of CMR, providing 3D definition of cardiovascular volumes as well as contractility. And we can have myocardial ischemic injury, meaning impaired function due to irreversible infarction, transmural infarction, or potentially reversible things that I'll be getting into further. How do we define viability, and how should we begin to think about viability? Well, it's traditionally defined by recovery of myocardial contractile function, improvement of thickness, improvement of ejection fraction. Is that in and of itself enough? I would posit to you today that that's insufficient. That fundamentally we should be defining viability or absence of viability on a cell-specific tissue-based substrate level, namely the intrinsic presence or absence of living myocytes. And I'll convey to you why that's important. What I would also posit to you is that CMR is the most accurate means of assessing this concept, meaning detecting prior myocardial infarction. And that the absence of abnormal enhancement on CMR is a strong predictor of prognosis and evidence of residual viability. So here's early data done during my fellowship in conjunction with Dr. Ray Kim and Bob Judd, who were respectively first and senior authors on this work. This is a dog model of infarction in which coronary ligation was performed, and CMR was performed immediately prior to animal sacrifice. one can see a near one-to-one agreement between the size of the infarct on CMR and that which we can see on on TTC staining ex post vivo. Additionally, and importantly, not only is infarct size equivalent, but there's a one-to-one correlation that we can see as well between thickness of infarction, transmural extent of infarction, and we'll talk about why that is important. So how had we traditionally seen myocardial damage? Techniques such as SPECT or PET had been used to do so. And these are fantastic techniques for areas of large infarct. So here's a dense perfusion defect shown on SPECT imaging, and an agreement in terms of what we see on CMR and histopathology. But we've also shown that, that small infarcts are traditionally missed on SPECT imaging. Here are three examples of small infarctions on TTC staining, shown in the areas of white on histopathology, corresponding to what we see on CMR and missed on SPECT. In fact, what the reason for this may be the fact that CMR provides a 5 to 10-fold improvement in spatial resolution versus both PET as well as SPECT techniques. Is viability imaging enough? I would make the case alone, the case that it's not. Simply identifying whether tissue is viable misses half of the equation. Namely, infarction can be present and it needs to be imaged adjunctively, and only CMR of all techniques can do so because small infarcts matter. Here's a prognostic data. This is by Ray Kwong in terms of the bigger group. Nearly 200 patients with no prior myocardial infarction undergoing CMR, showing that the presence of hyperenhancement in and of itself was a strong predictor of prognosis in patients with known coronary disease as well as those without. Importantly, as I alluded to earlier, of all techniques, only CMR is capable of imaging infarct transmurality, meaning the extent of infarction in relation to the actual wall thickness. And that's a key premise in terms of our ability to interpret likelihood of functional improvement. So here we see typical examples of infarction: small subendocardial on the infarct on the left, transmural infarct on the right. And when one looks at data, this is data from Ray Kim and Bob Judd, looking at likelihood of functional improvement, one can see a near one-to-one correlation between transmural extent of infarction on CMR and likelihood of post-operative recovery. So these are CMR studies done before cardiothoracic surgery, bypass surgery, and CMR studies done afterwards. Here's a typical example of this, two patients done in our lab. Both demonstrate extensive thinning as well as impaired function. Both are abnormal on SPECT exam, but both have, when we look, very different viability assessment on LGE CMR. The image on the top shows a transmural infarction. The image on the bottom shows a subendocardial infarction. And here's the data post-CABG. Marked difference in terms of likelihood of contractile function. Now, both of these, if we just looked at wall thickness preoperatively, might have been written off as non-viable. The key component is that LGE differentiates the two. Okay. And the point, as made earlier, is that if this functional muscle is not dead, then revascularization improves prognosis. So here's additional multi-center data demonstrating this concept. So is the notion that thin myocardium is a rare phenomenon? Should we be writing patients off simply based on contractility, on akinesis, dyskinesis, or even thinning? This is data from Deepan Shah, but from Houston Methodist, looking at this concept. These are patients with advanced coronary artery disease being considered for bypass surgery. Nearly 20% had myocardial thinning. And of these thinned reasons, only 20% of these had, about 20% of this patient population had limited scar. I think they loaded my wrong talk. So we talked about viability assessment. Let's talk a little bit about ischemia assessment. The key concept being that CMR is capable of integrating perfusion information together with viability assessment. So we can look at blood flow to regions as well as myocardial injury, as shown earlier. When we look at the performance of CMR perfusion, a number of studies have shown superior diagnostic performance in relation to SPECT imaging, again relating to improved spatial resolution, as shown earlier. This is data from CMARC showing improved area under the curve for overall detection of obstructive coronary artery disease. I could show you similar data from the recently completed MR IMPARC study, again, improved by performance. But what about prior multi-center studies on viability, and what can we learn from them? When we look at STITCH, which is one of the largest studies looking at this concept of over 600 patients, no significant interaction between presence or absence of viability and beneficial effects of CABG. Why might this be? Nearly 3/4 of patients in STITCH were done by SPECT, half were done using dobutamine echo. How about the recently completed REVIVE BCIS2, in which patients with seemingly quote-unquote viability were randomized to either guideline-directed medical therapy alone or multi-vessel PCI. Neither strategy resulted in demonstrable improvements in ejection fraction at either 6 months or 12 months. And revascularization by PCI, despite viability, did not result in a lower incidence of mortality or hospitalization. So why might this be? And what have we learned? Is viability imaging dead? When we look at these prior studies, a number of key concepts come across. When we look at STITCH, only 1/3 of the patients in STITCH actually had multivessel coronary artery disease, and only 2.3% had actual left main stenosis. Viability imaging was heterogeneous, and as said earlier, viability was defined as a binary phenomenon. When we look at BCIS2, strikingly high proportion number of patients had disproportionate LV dysfunction in relation to extensive coronary artery disease, suggesting that some of these patients may have had non-ischemic cardiomyopathy, again not assessed in BCIS2. These are key concepts that are going to be studied further in the recently initiated STITCH 3C trial, for which NIH, together with Canadian funding, is going to be leveraged to assess these questions. So in summary, I would make the case that CMR is a robust and useful tool for assessment of ischemic heart disease. It's the emerging gold standard for viability imaging, and that mixed results in prior clinical trials may in part be attributable to both trial design as well as patient substrate. Thank you very much.
Thank you, Dr. Weinsaft, and especially grateful to have you here today. Thank you for coming from up the road at Cornell and lending your expertise to our cardiovascular meeting. Our next speaker is also a cardiologist. So this is the International Society for Coronary Artery Surgery, but we really do try to live the heart team approach. And so our first two speakers today in our plenary session are both renowned cardiologists. Dr. Patrick Servois, I'll be speaking about at more length later. He's an exceptionally renowned and accomplished contributor to the field of cardiovascular medicine over several decades, and I'm grateful to be able to call him my personal friend. He's going to talk to us this morning briefly about FFR and CT-FFR, and later today at 11 o'clock at the 10:45 session, he'll be giving our keynote address for the entire meeting. Professor Servois.
Thank you, John. So that's the title of the talk. I mean, 3 years ago, there was a state-of-the-art review of the fractional flow reserve-based coronary artery bypass surgery. It's still one of the best evidence and report on that field. As a matter of fact, there is a few studies. I mean, one study which has been reported 3 times by Todd and Fournier, which is a retrospective study sometime with propensity match and a quite long follow-up. In this study, 71% was arterial, 29% was saphenous vein graft. The angio guide, that's the percentage of arterial and saphenous vein graft. And there was no statistically significant difference between group in MACE. When they published for a second time the paper, They came to a more refined analysis, few MACE in the FFR guide group, 21 versus 26, but you could see the confidence interval was not there. And in their last paper, they said that FFR guide cabbage significantly impact patency rate of arterial graft, but not saphenous vein graft. 3 retrospective study. 2 prospective, Botman and INPAC. You could see the follow-up 1 year, 6 months, prospective. Bypassing non-functionally significant stenosis result in a greater rate of graft occlusion at 1 year. Very impressive, 21.4% in non-functionally significant versus 8.9 in functionally significant. And then the study of IMPACT, preoperative FFR measurement of the target vessel is a significant predictor of anastomotic functionality. You could see the last 2 studies are randomized trial with a quite short follow-up, 6 months and 1 year. You could see the percentage of arterial, and there was no between group difference in graft failure rate, and no difference in overall graft patency, and no difference between arterial versus saphenous vein graft failure between FFR-guided and angiography-guided groups. That's the difference between retrospective, prospective. So graphically, you can show that the size of the circle represents the study population, the proportion of arterial graft in the study are plotted on the x-axis, and the absolute proportion risk reduction using fractional flow reserve on the y-axis. The 2 randomized trials, Fargo and Graffiti, did not show any difference. Quite recently in CCI, there are the influence of the FFR on graft patency, systematic review, and patient-level meta-analysis by Todd again, and they can see that now they publish an odds ratio of 5.74, putting together Botman, Fargo, Graffitis, IMPACT, and you can see the logistic regression model, the hazard ratio increase when you go above 0.8 for the FFR. But the MACE is not affected, at least for a period of 2 years, either angio-guided or FFR-guided. So this is the new way to do it with multi-slice CT scan, looking at the plaque, removing the plaque, creating the luminal surface, looking at the myocardial mass, and then the finite element, and using quite complex mathematical equation, Navier-Stokes, and then you got the FFR proximal to the lesion and the FFR distal to the lesion. So what is the capacity of the fractional flow reserve calculated from computed tomography? You could see the area under the curve when you compare with the real things, angiography plus the pressure measurement. The area under the curve is 0.94, superior to the PET, superior to the CCTA, and superior to the single photon emission computed tomography. Now, with John, we did this study, fast-track cabbage trial of first in men, 114 patients referred to CABG by conventional heart team using invasive coronary angiography. Then they underwent a CCTA with fractional flow ratio. The data were transferred to a core lab blind for the ICA, multiple assessment, and then the core lab sent the result back to the site, but to a different heart team, and a heart team which is CCTA planning and operating heart team, surgeon and radiologists blind to ICA. They operate 111 patients. Now, if the surgical planning was deemed not feasible, then the surgeon was given access to ICA and unblinded. That's the feasibility assessment. After the bypass surgery, there was a 30 days follow-up of CCTA for the safety assessment in 102 patients. This is the assessment of the right coronary artery. There is three focal lesions. The first one is calcified. The second has a small side branch. The distal bed is 1.5 millimeter. This is the LAD. You could see that there is a severe lesion at the end of the left main of the circumflex is involved, and of course the LAD on a very long segment. The distal bed is good, 1.8 millimeter. If you make a syntax score, the total score just for the left is 46.5. And then you go to the intermediate, who has two focal lesions, 4 point, and then the obtuse marginal is involved in the main stem, distal to the main stem. There is a second lesion calcified and a third one. So the grand total for the anatomic syntax score is 58.5%. Then we look at the functional assessment with the fractional flow, and you could see you have to do the LAD, you have to do the intermediate, you have to do the obtuse marginal, although the surgeon will have to put the bypass quite distally. As you could see, the right coronary artery has a fractional flow reserve of 0.8, borderline. There is a drop here, but the question was, should we graft the RCA? Looking at the plaque, which is lipid-rich with a fibrous cap and eccentric, we convinced the surgeon to do it. Now, today we have something more sophisticated, which is the microvascular resistance, the myocardial perfusion, and the myocardium at risk. This is the classic heart flow. Today we have the synthetic tree based on the Strahler model for fractal division, which gives you a better ID. The downstream coronary circulation is coupled with the myocardial model. You have a simulation of the myocardial blood flow, and the simulated perfusion with multi-slice CT scan is very similar to the PET examination. And the focal FFR CT indicate the subtended myocardium at risk of ischemia. So we also provide the surgeon with the percentage of myocardium at risk. You could see the two sides here where you have an FFR CT below 0.8. You will have to do the posterolateral and the obtuse marginal. You can skip the first diagonal, but you will have to do the LAD. And you know the percentage of myocardium at risk in this LAD and in this circumflex 7.5 and 21.1. So this is the baseline characteristic of the fast track. As you could see, the age, the medically treated diabetes, current smoker, COPD, peripheral vascular disease, creatinine clearance, and left ventricular ejection fraction. You could see the type of the syndrome that they had, proportion of 75% with three-vessel disease, 25% with left main. And then we had 4.7 major epicardial vessel territories by CCTA and 4.1 by ICA. And you could see that the way we define the major epicardial vessel using that technology, this is an example where there are 4 major epicardial vessel territory who have to be revascularized. The anatomic syntax score derived from the CCTA, 43.6, from the FFR, 41.2. Coronary segment, more than 50%, but with an FFR below 0.8, 92.7%. Coronary segment greater than 50%, but with an FFR above 0.8, 7.3, 51 vessel, and the surgeon did not bypass 42 of these vessels. I'm finishing to the 30 days post-CABG. The CCTA is repeated. You could see in this case the saphenous vein graft was put very high, even proximal to some kind of lesion. The Lima was great, with an improvement of the FFR from 0.50 to 0.91, And the saphenous vein graft, you remember, quite distally on the obtuse marginal, improved the FFR but did not normalize 0.59, 0.79. So this is the follow-up CCTA outcome at 30 days. There was 102 controlled by CCTA. In this patient, there were 366 anastomoses. The anastomoses were patent in 92.6%. There was occlusion in 7.4%. And from this occlusion, 27, only one has an FFRCT above 0.8. You have to compare this series with the series of Anne, who had a CCTA pre-discharge. The patency was 95.3%, the occlusion 4.7, but he excluded 25 patients with symptoms of sign of myocardial infarction. I like the series of Sousa, CCTA 5 weeks after a bypass surgery, patency 92.4%, very similar to what we have found, and occlusion rate 7.6 versus 7.4. So in conclusion, the impact of invasive FFR performing the native circulation on the late patency of arterial and venous graft has been controversial. And the recent patient-based meta-analysis does not show difference in MACE rate after angiography of FFR-guided grafting. FFRCT is reliable and seemingly influence the decision-making in the treatment of patients with three-vessel disease. A combination of FFRCT and assessment of ischemic myocardium at risk in planning and performing bypass surgery with the sole knowledge of CCTA anatomy and FFRCT without any visual information provided by conventional coronary angiography in patient referred for CABG is feasible and deemed safe in a selected population with chronic coronary syndrome and low surgical risk. Efficacy and confirmed safety will have to be demonstrated in a randomized control study. That's the syntax 4, which is in negotiation with the FDA.
The next speaker is Dr. John Pascas, 3-year update of the FAME3 trial.
Good morning. It's a very tough act to follow. Dr. Sorois and Dr. Weinsaft, I'm just a humble plumber of coronary arteries, but I'm going to give a data talk just now, the 3-year update of the FAME3 trial. These are my disclosures. And just to put it in context, these are the FREEDOM trial data at 5 years. Remember, this is patients with diabetes randomized to PCI versus CABG with a primary outcome in favor of CABG, including death in favor of CABG at 5 years of follow-up. At 7 years, that survival advantage continued for CABG. The syntax trial you're all familiar with. Dr. Sorois is the father or co-father of that study. It remains a landmark trial in cardiovascular medicine and surgery. And as you see, for the overall cohort at 5 years, the composite primary endpoint was in favor of coronary bypass, with individual components of that composite primary being in favor of coronary bypass for myocardial infarction, repeat revascularization, MACE, and death, stroke, or MI. This is the multivessel disease group, and we see the interesting finding that the benefit of coronary bypass was different in different syntax groups, one of the major contributions of Dr. Sorois. At 10-year follow-up for three-vessel disease patients, there's a mortality benefit for CABG over PCI. So this is the background to some of these other trials I'm going to show you, because they all set up to produce the FAME3 trial. Now, COURAGE was a study of optimal medical therapy with or without PCI for stable coronary disease. And the conclusion was that an initial management strategy in patients with stable coronary disease, in that setting, PCI did not reduce the risk of death, MI, or other major cardiovascular events compared to optimal medical therapy. And these are the endpoint figures from that 2007 New England Journal paper, which basically shows overlapping event rates for PCI with medical therapy versus medical therapy alone in stable coronary disease. Now, the original FAME trial was to examine where the functional flow reserve, which we heard about from Dr. Sorois with more advanced technology, compared to just conventional invasive coronary angiogram, would improve the outcomes with PCI. And the conclusion was that routine measurement of FFR in patients with multivessel disease who are undergoing PCI significantly reduced the rate of complications, and so improved outcomes with PCI. So FFR-guided PCI outperformed routine angiogram-guided PCI, and this was published just 2 years later, also in the New England Journal. Now that set up the FAME-2 trial, which was fractional flow reserve versus angiography for multivessel evaluation, basically 5-year outcomes with PCI guided by fractional flow reserve. And the conclusion was that in those same stable patients, an initial FFR-guided PCI strategy was associated with a significant reduction in the primary composite endpoint of death, MI, or urgent revascularization 5 years on. And here's the take-home message from this 2018 New England Journal paper, again demonstrating that PCI beat medical therapy when PCI was guided by FFR. So here's the FAME-3 trial. The question is whether fractional flow reserve guided PCI would actually beat CABG. Bill Fearon, an interventional cardiologist from Stanford, led that trial. And here's the design of it. You see it's about 1,500 patients randomized to FFR-guided PCI or routine and invasive angiogram-guided CABG. So it's an interesting idea. CABG has traditionally been based solely on coronary angiography, and here now, best state-of-the-art PCI would be based on FFR. And then we look at a primary endpoint of death, MI, stroke, or repeat revascularization at 1 year, and secondary endpoints at 3 and 5 years for death, stroke, and MI, not including repeat revascularization, which is a little bit interesting. I wasn't part of the design of this trial, but you note that the primary endpoint at 1 year is different from the endpoint at 3 and 5 years. So here's the 1 year endpoint, and basically PCI was not non-inferior to CABG, which, while statistically speaking, one shouldn't say that correlates with inferiority. I've put it there in that little text box because that's what it means to a simple-minded surgeon. At 1 year, PCI was inferior to CABG in terms it did not reach non-inferiority. And interestingly, according to the syntax scores, you can see that CABG had similar performance across the syntax scores, while PCI did not. Very much consistent with what we saw in the original syntax trial. That's to say that complexity of coronary disease impacts outcomes with PCI, while it does not impact outcomes with CABG, an important difference between those two alternative therapies. So here's the 2022 follow-up paper. Excuse me, that was the paper for the 1 year data, and here's the accompanying editorial. So this is again from an interventional cardiologist, Fred Welt, and he concludes the totality of the data to date supports CABG as the standard of care for patients with stable multivessel disease. Although the use of FFR may improve outcomes in patients undergoing PCI, the results of the FAME-3 trial indicate that with current techniques, FFR-guided PCI does not result in outcomes as good as those of CABG. And then it even emphasizes the important role of optimal medical therapy for both groups. I think that's a very, very important message for us as cardiac surgeons and cardiologists taking care of coronary bypass patients. Here we are now with the 3-year follow-up data, and I'm indebted to Philippe Kasselman, who provided me with some of these slides. He was one of the members of this group. At 3-year follow-up, there was no difference in the composite of death, MI, or stroke. And again, there was a change. That's to say that repeat revascularization was not part of the 3-year endpoint. And that was not because it didn't gather data for it, but it was rather a pre-specified primary endpoint, secondary endpoint, excuse me. So here at 3 years, you see the PCI versus CABG. The p-value is 0.07, does not quite reach statistical significance, and for the endpoint of death, MI, and stroke without repeat revascularization. Here you can see that the functional syntax score does predict outcomes with PCI and not with CABG. Again, typical of what we've seen in those other studies. Importantly, I think, you can see that the composite of death, stroke, and MI did not quite reach statistical significance, although MI itself did. Repeat revascularization data was available, but was not part of this secondary endpoint at 3 years. And if you did include it, of course, using the same composite endpoint as we had for the 1 year time frame, there was a highly significant benefit of CABG over PCI. But the conclusion is that there was no difference. So one has to be cautious in reading this study. I encourage our surgical colleagues to understand the data when you're in conversations about these sorts of studies. Thank you.
Thank you, Professor Puskas. And we're now happy to introduce Professor Hu from Beijing, from the world's biggest hospital performing CABG, and he's a total expert in coronary imaging through the use of different modalities, and he will share with us today his experience working in the world's largest CABG hospital.
Thanks for the introduction, Dr. DeFranco. And it's my privilege and my proud to be here and give a brief introduction on the CABG in our hospital and some relevant research work of coronary imaging in CABG patients. So let me, the disclosure is known. So let me start with a brief description of the volume and the mortality of CABG in the Fuai Hospital. So you can see that during the past 10 years, there are 3,000 to 4,000 cases were performed annually in Fuai Hospital with a mortality below 0.5%. And maybe this year we can hit a new record of 5,000 cases. And the outcome percentage are also decreasing from nearly 70% in 2006 to about 1/3 in recent years. And more multi-arterial and no-touch saphenous vein graft are used. And with such high volume, it is relatively easy for us to further enrollment for some large randomized trials. Here are some examples. This is a randomized trial for rosuvastatin. So it's randomized trials including about 1,900 patients, and the study shows that statin therapy failed to prevent post-operative AFib or myocardial damage. And this is another randomized trial called Optima trials, which include about nearly 4,000 patients. And the study shows that high-dose tranexamic acids can reduce blood transfusion rate without increasing adverse cardiac events. And the China pendency trial, also called no-touch versus conventional vein harvesting trial, was also enrollment about 2,600 patients. And the study, which was updated with Dr. Tan yesterday, shows that the no-touch technique can significantly reduce the risk of vein graft occlusion in about 1 to 3 years. So after we initiated this study, the post-operative CG angiogram was routinely performed in our hospital because now it can be examined in a very efficient manner with a relatively low cost for the patients. So based on this post-operative CT angiogram, we have conducted a series of studies. This is a study based on 6 to 9 years coronary CT angiogram follow-up. It shows that chronic total occlusion was found to be associated with high risk of graft failure. So about coronary imaging, maybe the functional evaluation is one of the biggest change in coronary imaging, maybe that can alter revascularization strategy. And the FFR is a pressure wire derived function evaluation has proven that can get PCI for improving patient outcomes. How about the role between FFR and CABG? There are large two trials that showed previously by Dr. Saray in previous presentation that these trials didn't fail to show the advantage of FFR-guided over angiography-guided CABG on clinical outcomes. But we know that arterial grafts are sensitive to competitive flow, which can be accurately assessed or evaluated by FFR. And the IMPACT trials indicate that the functional evaluation may play a role in guiding arterial grafting. However, there are several limitations for FFR for CABG patients because when most of the patients refer to CABG, they don't have a result of FFR, and FFR is relatively cost is high, and there is a potential side effects, and it's invasive. And QFR, which is quantitative flow ratio, is alternative or simulation of FFR that was based on three-dimensional angiographic reconstruction and fluid dynamics. It can be acquired only based on the image from the previous angio. So it's relatively suitable for us CABG patients. And the Favor to China study shows that QFR is highly consistent with FFR, demonstrating a good diagnostic performance. And in the Favor 3 China study, which is a multi-center randomized trial, shows that QFR-guided PCI can also improve the patient outcomes compared to angio-guided strategy. So how about QFR and CABG? Since the QFR can be retrospectively collected, we conducted a series of studies investigating the relationship between the QFR and the CABG patency. And in a study that was published this year by Dr. Tan, shows that based on the data from China patency trial, the functional complete revascularization, which was judged by QFR, and anatomical incomplete revascularization were associated with significantly higher risk of compensating of MACE at 1 year. But the anatomical complete revascularization still shows the lowest MACE rate at 1 year, although without a statistical significance. I think maybe like what Dr. Bruce Lido and Mario Godino mentioned in a commentary on FFR and CABG. FFR may not be that useful determining whether or not the vessel should be grafted, but it may be useful deciding whether or not to use an arterial conduit to graft a certain vessel. This is a study that we designed specifically for the LITA to LAD graft. And this study shows that patients with higher QFR with more than 0.80 shows a higher LITA failure rate and even a cumulative MACE rate. And this result was published this year on JAHA. And another study conducted by Dr. Tian shows that a higher QFR was associated with risk of arterial graft occlusion, which mainly consists by Lima graft. But there was no significant association between QFR and asaphenous vein graft patency. So maybe it's related that vein graft patency may not be that sensitive to competitive flow. Since the radial artery is one of the conduits that may be most sensitive to competitive flow, so we designed specifically a study for the radial artery patency and its relationship with QFR, which was published on Circulation as a research letter this year. And in this study, it shows that once the QFR is more than 0.71, the radial artery patency could reach up to a devastating patency of the occlusion rate of 40%, which is sometimes somewhat unacceptable for surgeons. And when we compare the QFR and the degree of stenosis evaluated by angio, the discriminatory power was far better favoring QFR. So the QFR is maybe a far better tool when deciding the competitive flow compared to the degree of stenosis. And in a mixed effect multivariable Cox model, after adjustment, the QFR with more than 0.71 is the one variable and the only one variable that was independently associated with a risk of radial artery occlusion with an adjusted hazard ratio of 12.58, which is surprisingly high. And there are specific range we maybe need to pay more attention to is for patients with a stenosis of between 70 to 90%. We can see the QFR was discretely distributed in this 70 to 90 stenosis range, and maybe QFR may be more useful in this group of patients. So let me conclude. Their FFR to direct revascularization may not be that logical during CABG PCI. Functional evaluation may play a role in target vessel selection for arterial grafting, and target vessel with a QFR more than 0.71 are associated with a low radial artery graft patency. So that's the end. Thanks for listening.
Many thanks to all of our speakers this morning. Thank you, Dr. Hu, for bringing your expertise from the Fuwai Center, the largest coronary bypass center in the world, and to Dr. Weinsef and Dr. Sorois for lending their wisdom to our conversation this morning.